You're listening to Fit Pro Sessions with Parallel Coaching, Season 4, Episode 9. Hi, I'm Neil Bergman. In today's podcast, Hayley and I are talking all about common clinical conditions, comorbidities and medications. So stay tuned.
Hi, I'm Neil Bergman.
And I'm Hayley Bergman. Over the last 10 years, we've helped thousands of fitness professionals to get qualified, learn with simplicity and coach clients with confidence.
We're the first to say that learning and being a fit pro doesn't have to be hard work, and that with the right structure, support and resources, you can become a confident and knowledgeable fitness professional that is dedicated to more.
So how do you learn, qualify and kickstart as a fit pro? This is the Fit Pro Sessions podcast with Parallel Coaching.
I can't believe we're on Episode 9 already.
I know, it's great.
There's only one more to go. So there's 10 episodes to Season 4, which is obviously all about common clinical conditions, the rise of them. We've gone through pretty much all of them now. And today we're talking about comorbidities, we're talking about medications, which a number of you have asked for more information, more knowledge and more confidence on.
Which I think is kind of the golden thread that joins all of those little beads that we've had so far together.
So we're going to have to jump into some SMART goals today. We're going to have to jump into some planning today, exercise selection today, and really kind of drawing this season to a close. And then next week will be the final episode where we do kind of the final close on exercise referral, working with clients that have common clinical conditions.
Yeah, and how
I'm actually quite sad. I've enjoyed all of the podcasts, but this season I've absolutely loved.
We've had really good reviews, and I think it's because it goes into so much more detail and
Yep.
depth that wherever you've been as a fit pro in the journey, you can kind of join in and learn something.
And I think because so many people get into fitness because they want to help more people, they want to help people.
Yeah.
I think this really does hit the kind of a nail on the head with helping people not just tackle, say, their weight loss around, say, obesity and overweight, but a clinical condition that impacts quality of life.
I was talking to a learner yesterday, and they were saying that they got into fitness because they wanted to help people transform their lifestyle like they did.
Yeah.
All those years ago when they lost the weight and wanted to found fitness, fell in love with fitness, loved it, wanted to do the same for others. And then as she's been going through her PT qualification, she got so ingrained into the advanced PT training system, it felt so distant away from the reason why she wanted to become
That's
a
really
PT
cool.
in the first place.
Well,
and now she's finding that again.
Well,
lovely.
let's make today then. Let's try and kind of wrap some of those advanced training systems into working with clinical conditions. Like, there's no reason why somebody with any of the conditions can't be doing a superset or a triset or a giant set.
Yeah.
But it's having that method to its madness and saying, justifying why I'm placing it there, and not seeing it as an advanced system. It's just the right thing at the right time for the client, and that's what a client-centered approach is, right?
Yeah, exactly. That it's not about, because I'm doing a tricep, I'm building loads of muscle.
Yeah, completely.
There's actually the right time and place.
Yeah.
There's no right or wrong, it's only appropriate.
There we go. Amazon is safe and effective.
Oh.
Boom. So, I just want to thank everybody for the support on the podcast. Not just for Season 4, but across the board. The numbers of views every week is going up. So we're clearly hitting and reaching more people, which is our goal.
Yeah, it's great.
And obviously, we don't get paid for this. It's something we put out into the big wide podcasting world for free. And that comes down to you guys supporting us, spreading the message, tagging us in on your Facebook stories, Instagram stories, liking, commenting, sharing, and kind of beating the parallel drums. So high five to you guys, because we might have kind of done the hard work of putting it together, but you guys have done the hard work of actually getting it out there. So
yeah, thank you for sharing.
Superb. Love it. Thank you very much.
I love it.
So today we are jumping into comorbidities, and quite often on the exercise referral course, not so much at level 4s, because at that point it would be assumed knowledge, but they say, what is a comorbidity? And it's kind of getting your head around that word and what it means. So
Which is
over to you.
essentially just two or more diseases or conditions that appear simultaneously.
So you have a primary condition, which would be, let's say, let's go with obesity.
Yeah.
And then the comorbidity would be the next condition.
That happens simultaneously, so at the same time they've got several conditions.
Yeah. Or is caused by the primary condition. So if somebody was overweight, obese, then their secondary condition or comorbidity would be type 2 diabetes.
Yeah, nice.
And then the next one could be hypertension, for example.
Or then if they get stress or anxiety or depression, they become comorbidities of the first one as well.
And quite often, one condition causes or is the catalyst to start another condition. For example, obesity does cause type 2 diabetes.
Yes.
And then there's
Massive
some
risk factor.
yeah,
That's it, a
that's
risk
the
factor.
factor. Yeah, so I don't know what I just said. I said a word and it wasn't. I think I just ended one of my words into your words and it didn't make sense.
Did I cut you off?
Yeah, no.
Obesity into type 2
It's a
diabetes.
risk factor. There you go.
Yeah.
Cool. Whereas, say, there's some conditions that are correlated, but they're not a cause and effect relationship.
Yeah,
For
exactly.
example, low back pain and obesity.
Yes.
Just because somebody's obese doesn't mean they're going to have low back pain, and if somebody has low back pain doesn't mean they're obese. However, you might see somebody with a correlation that does go hand in hand, but they don't cause each other.
Yeah.
Nice.
That was very eloquently said.
I do try.
Yeah.
And then now and again, I lose my words and I amalgamate into yours, and I have no understanding what language it was in.
So the problem with comorbidities is that we've been looking at them as individual conditions.
Yes.
All the way through this season so far.
That's been very deliberate. I'm going to put that.
Yeah.
That's been very
It
deliberate
makes it simple.
because
Makes
it's
us
allowed us
understand
to
it.
focus. Yeah.
Exactly. The only difference to that is maybe metabolic syndrome, where we started to weave in the multiple different types of
Yes.
conditions. Metabolic syndrome is a perfect example of comorbidities because you've got 3 conditions sitting side
So
by
there was
side.
5 things you had to have metabolic
5
syndrome.
risk factors.
5 risk factors, 5 conditions, and if you had 3 of them, you had metabolic syndrome.
Yeah, so it's like this amalgamation of lots of symptoms and risk factors
Yeah.
together. So as a sort of result, what you find is that rather than looking at just an individual condition, is that you still want to look at the individual client as an individual. And if that individual has multiple conditions, we now need to factor in multiple problems, multiple medications, multiple contraindicated exercises. We end up with a lot more to factor into our planning.
Yes, completely.
And that,
But ultimately, one condition, a client refers a PAR-Q.
yes.
So if a client has low back pain, they refer a PAR-Q, even though they might not have any medications, they've not been to a GP about it, they don't see it as a major problem, but they have low back pain. It might be non-specific low back pain. It might be a yellow flag, but they have referred a PAR-Q.
Yeah.
It might be that they have a higher blood pressure reading, and you could say, well, you're stage 2 hypertensive today. It's just a timestamp of current status.
Yes.
It's about referring a PAR-Q. It's when it becomes kind of funky, I suppose. It sounds weird. I enjoy it for when a client refers for multiple conditions, because now you can really get into that health-related goal and start unpicking, this holistic approach that's going to manage the conditions and improve not just get them towards their performance-related goal, but get them to the outcome goal of health.
Yeah, and it's multidimensional then, isn't
Yeah.
it? Because you've got loads of things to think about. And obviously, the more conditions or diseases they have,
Yeah.
the more problems you're likely to face, the more complex the planning becomes.
There's more it's more complex. There's more things to think about. It doesn't necessarily mean it's going to be any harder.
No.
And I like to use this analogy of deal with the elephant in the room.
Nice.
Okay,
That's
so
very appropriate.
yeah, so go for it. You've used this morning, in fact, with a learner on the phone. What do I mean by that? What do I mean?
What do I
Explain
mean
my
by
meaning.
this? So the elephant in the room, if you take the analogy of like the elephant and the mice, if you want to deal with a problem, you've just got to remove the elephant and the mice will disappear. You don't go and try and sort out all the different little mice and then still have the elephant running
What's
around.
the one kind of common denominator, the
big
one
thing?
big thing that you go, if I dealt with this, it would also clear away all the mice.
Yeah.
So I like to deal with the elephant in the room.
And
when
the
you've got lots of
elephant in the room?
Yeah.
Could be the biggest cause of the reason why they may be having lifestyle problems or lifestyle factors.
Yes.
So you might turn around and go, actually, the elephant in the room is the nutrition.
Yes, exactly.
Then that might be some of the reasons, some of the causes behind their obesity, their diabetes and their hypercholesterolemia and their hypertension, that maybe I could start clearing things up with one tweak
Yeah.
rather than feeling like I've got to give them everything
And
all
I think
at
this is
once.
maybe where, say, like PT or yoga or Pilates course doesn't do the Fit Pro, I'm going to be honest, a huge justice of leaving the course with the confidence and competence and knowledge of challenging someone's nutritional habits and understanding what's inside their remit as a trainer, as a coach.
Yeah.
Because it's far greater than what we think it is or what we learn to believe it is on course. You have a lot more scope. And I think once you hit people that refer a PAR-Q because of a condition and you're working with them, I found the elephant in the room to be a nutritional approach.
Yeah. Yeah,
because
absolutely.
the minor tweaks to someone's nutrition can have huge changes across the board.
And secondary to nutrition, I'd probably say NEAT.
Yes, NEAT, definitely. So non-exercise activity thermogenesis. So challenging someone's non-planned exercise.
Like that can make a massive difference to just being able to walk. Generally,
I think if we
is a
went through
great
all
way.
of the episodes so far, I know we've said at some point in that episode that one of the causes to all of those conditions is inactivity.
We've probably said it on everything.
Is not moving.
Yeah.
And so by moving more, we actually challenge the condition.
Yes.
We go head on and fight the good fight towards the condition.
So any amount of moving more would do that. It doesn't even need to be.
Yeah.
It doesn't need. This is probably the biggest thing about exercise referral or working with common clinical conditions and health related clients. To me, is the fact that it doesn't need to be a bee sting.
No.
It doesn't have
A
to
bee
be
sting?
a bee sting. It's not a bee sting
Yes.
session. It's not a session that you
But
have to be
anybody-
10 out of 10 to get a result.
Anybody can write a program. You know, I could
makes you hurt.
that makes you hurt or gives you muscle soreness. Like I could go across the road to somebody that, you know, a mate of mine that doesn't know anything about fitness, and I say, could you write me a program of how to train? And he could probably recall a number of exercises and go, well, you're going to do squats, you're going to do lunges, you're going to do burpees, and I'd wake up the next day with a program that's given me muscle soreness. Anybody can do that. What we're talking about is making it science-backed and making it smart.
Yes, so they actually get the result that
Yes.
they're after in the long term and in the short term.
Exactly.
And the other part of that is being smart. Like you said, it's that safe and effective, but it's being smart in that programming. And when you've got comorbidities, just to bring that back to this sort of multiple conditions.
Yeah, we're going to go off on a tangent.
There's a lot of contraindicated exercises per condition
Cool.
anyway.
I want to pause you there because we've used that a number of times throughout this season. What does contraindicative mean, or contraindications?
So the word contraindicate means that you cannot do.
Yes, cool.
So a contraindicated exercise is something that you shouldn't be doing or cannot do with somebody that has that condition.
For example, somebody that's, say, hypertensive, that has high blood pressure, okay,
Yeah.
doing an isometric exercise, which is, for example, a plank, whereby you're stressing the muscle is under tension, but there's no change in the length of the muscle, so everything's isometric, okay. Blood pressure will increase in the short acute term,
Yeah.
which will have an impact on blood pressure and therefore could cause dizziness, could cause vomiting, they could even pass out.
Yeah.
Okay.
So then you say, well, it's contraindicated to do a plank or do an isometric exercise with somebody that has high blood pressure.
So how do I think that's the biggest learning curve, is how do I adapt the exercise to the client and the client to the exercise?
And there's a really key part in this about how you bring it together before you do your planning.
Yeah.
So we talk about something called SOAP several times before.
Yes.
And SOAP is basically a protocol where you go through your screening and your planning with your
Yeah.
client. So you start off with subjective, which is the questionnaire,
Which
really
we
finding out about
consultation 1 and 2. So find out who's who in the zoo, what they like to eat, what they don't like to eat, what they like to exercise, when they last exercise, what's their training age, what's their condition,
Their
where's their
PARQ,
pain, their PARQ, all the
injury history.
everything, all the ins and outs. It's talking. I call that conversational coaching.
Yeah, it's
Yeah.
their goal setting as well.
Yeah.
And then you go into objective where you do the physical tests. So this could be like their blood pressure test, their
Yeah.
weight, their
Their-
BMI,
Hip to waist ratio,
yeah,
Yeah.
their squat analysis,
their peak flow for asthma or
CV
respiratory.
fit test.
Yeah, CV fit test.
all of that type of stuff that are
Perfect.
physical measurements. And then assessment. This next bit of SOAP. So we've got subjective, objective, A for
Assessment.
assessment. This is where I wanted to go with it because this
Perfect.
draws it together.
Yes.
So you take all your information from subjective, all your
love it.
information from objective, and now you layer on the rules for the conditions that they have.
Perfect.
So if they have comorbidities, you've got to layer on a couple of different rules.
So the rules,
hypertension, obesity,
Haley is, I suppose, is
contraindicated.
talking about here is that we have a fit principle for cardiovascular health for
The recommendations,
the recommendation of an apparently healthy fit adult, which would be, say, 3 to 5 cardiovascular sessions per week, 150 minutes of moderate intensity. Okay, as soon as you've now got obesity, you've got an obesity fit principle, or a low back pain, you've got a low back pain fit principle, okay, which are very clear. And now you're saying, right, so I've done my subjective, I've done my objective, my client's got obesity, they've got type 2 diabetes, and let's say hypertension. These are my 3 fit principles. Now,
and the things they can and can't do.
And the things they can and can't do. So for those of you that are on screen, you can see my hand moving. For those of you that aren't, just imagine in one place over here, the client that's their current status, 3 conditions: obesity, type 2 diabetes, and hypertension.
Yeah.
I've got clear fit principles of what I can and can't do with them as well, contraindications. And then over here, okay, so my hand's now to the other side of the screen, okay, is their goal or where they want to get to.
Nice.
And in an ideal world, the apparently healthy individual fit principles. Now, that gap between the two is going to be bigger or greater depending on the client's starting point. It's now my job to plan on a safe and effective program that logically progresses them across this chasm, across this bridge from point A to point B without them falling off. And falling off would be the client going, I fell off the rails this week, or I didn't quite do it this week, or I'm quitting, or this diet doesn't work. So they've probably tried a million gazillion times before to get from A to B, and now you're the first person that truly sees life through their shoes and their eyes and says, well, I get you, I know where you are, this is your current status, you want to get from point A to B, and I can help you across that chasm.
And that's your planning. And
that's my planning. So rather than saying, I want to do a plank and I want to challenge their core this way, it's what can they can't do, what's their current principles or laws of rules around their training for them, and then choosing the exercise based on the objective, not the objective based on the exercise.
Oh, amazing. Because what you just said there was that there's...
My brain was like going at a gazillion miles an hour.
The SOAP principle.
You might have to go on Spotify now if you're listening on iTunes. You might have to like slow it down by 0.5 of like to go, that was normal speed for Neil. I ran out of breath.
So it's that SOAP principle allows you to take your time over the subjective and objective, yes, and really have it differentiated. Assessment brings it all together so that you can make a clear decision on the principles you're going to put in place, the strategy that you have, yeah, and then that's your planning. And the difference, honestly, when somebody takes that approach, rather than just going, oh, obesity, we use this tactic. They have to do Tabatas. No.
Or even just the tactic of they need to be in a calorie deficit. Like, don't get me wrong, we need to be in an energy balance. We know we need to be in eating or consuming less calories or expending more. We get that. There's lots of other factors that come into this assessment of the person, especially with more comorbidities. So it's not even just a case of the client refers a PARQ. You've now got a doctor's note, and on that doctor's note, or consultant note, or physio note, or osteopath's note, there might be very clear, again, do's and don'ts based on that particular client. So they may have had, I don't know, let's go a knee replacement, or they may have had some surgery, or they may even have non-specific low back pain, and whatever it might be. But the medical world have given you a clear note of your green light. And that's what I love about it, not just from, say, well outside of an exercise referral scheme, because I've not really been in an exercise referral scheme for years. I've done it off of my own privately, which means when a client comes to me, I can now liaise and network with the medical professionals from a client and go, cool, what can I do with Bob's back? What can't I do? I give him a ring. Is it okay? Do you recommend I can do this? What's the intensity that you would recommend? At what point? What should I be looking for specifically in this client based on all of the other medications? And now my assessment is not just my knowledge, my competency. I've brought in the other medical professionals that are also have to be involved in order to move Bob forwards.
Yeah. For example, if they're post operation on their knee, for example, you would then want to be dealing with the physio to find out what kind of active muscles they're trying to activate, what range of movement are they looking for, what plane of motion are they doing the exercises in, and so you can start to incorporate those into what you're doing.
What I've loved about this is the majority of the people I've worked with have been guys in their between, I'm going to say 30 and 55 in a boot camp setting, and you might think that's crazy, but I've had loads of guys with loads of conditions and got phenomenal results, as in like majority of the guys had at least 2 to maybe 6 stone to lose, and had other comorbidities, and they'd all be in one group, okay, training early in the morning, and across, let's say, a 3-month period, the average guy was losing between 2 and 4 stone.
Great.
Okay. Now, the exercise selection wasn't just a series of exercise in a circuit-based format that I sat there the night before and went, hey, we're going to do this, 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 and this, and we're going to do that there, and well, that'll look fun, or that'll be hard. It was based on where the client current status is, looking at the fit principles, the kind of the notion of joints act, muscles react. Where are they all posturally? Where's my overall assessment of this group, of these people? And then saying, right, this is what we're going to do as a group, but then I might have Bob doing X on a particular station, or an adaptation for Dave over here, or something else for Barry over here, and saying, you're not going to do this, you're going to do X, Y, and Z. So knowing each individual, and before you knew it, they're all coming, this was a wicked session. I really enjoyed that. It was great fun. I'm coming back tomorrow.
And they feel good.
And they feel
and
good.
then they get a result long term.
Yes, because it's adherence at the end of the day.
Yeah.
You know,
And
my
on top of
objective is to make a client redundant of me. So they get to the end of an 8-week or a 12-week bout of training with me, and they're educated enough to go, well, I understand how to kind of count my calories, do a food shop.
Nice.
And
That's it.
I understand that, you know, if I enjoy it, I'm more likely to do it. I understand that, you know, I'm not going to act upon my emotions. Loads of things. There's loads of mindset things in there
Yeah.
as well, and that
It's-
3-pronged approach.
It's not just about the singular session.
Yes.
It's about how they all map together to get the outcomes. All
Yeah.
the physical sessions map together. Then the NEAT and how all of that non-exercise activity, thermogenesis, fits in, how the nutrition fits in, and how the mindset fits in.
Exactly.
So you end up with this approach that layers on information. And to start off with, if this is the first time you're thinking about layering things together, it might sound like a lot to consider. So use that strategy of that SOAP to bring it all
Well, that's
together.
what I love about the exercise referral course, is because you do a case study in that, and that could be a real life case study, or you could use a hypothetical one that we've made up. I can't remember the person's name in it, actually. Jack, there you go. How original. Okay.
How original. Jack Green.
Jack Green, who has 3 different conditions to deal with. So by the time you've gone through that, you've actually trained or planned for and gone through a full SOAP assessment, I suppose, of understanding, well, what would I do based on Jack? What would I do based on my life case study?
Yeah, perfect.
And it's kind of that slowly catch your monkey approach, because by the end of that course, you've built up enough knowledge and confidence and competence to go, well, I still am, I'm by no means an expert, but I've got the license to teach. And I think that's what any course actually allows you to do, is gives you that license to go out. Just like you do your driving test, you start off and you kangaroo the car and stall it. And
Mine was really bad.
I can imagine it was, to be honest. Let's not go there. But you do a number of lessons to get you to a point of going, well, I'm going to do a mock driving test, and then you go and do your theory, and then you go and do your main practical, and you go, well, I've passed. And that gives you the license to go out on the road with insurance, but that doesn't make you an F1 car racer, right?
Yeah.
It doesn't mean you're...
And you might not feel very confident.
And you might not feel very confident. And I suppose that's what any fitness course does. It gives you the license to go out and practice. And I think the real world teaching comes after the course.
Yeah.
But the course should definitely set you up for success, to give you enough knowledge, more than enough confidence to go and challenge these conditions.
Yeah, I like that as
Cool.
an analogy.
Yeah.
I love that as an analogy. And then also with comorbidity, so we've kind of spoken about the fact that they are more complex if you've got multiple conditions, but also the fact that medications can cause the onset of other conditions.
Yeah, that's crazy. That's always baffled me.
I know. Crazy.
Take this to help with that, but I'll give you this, and once you've got that, I'll give you this.
Yeah,
Bit of a
exactly.
riddle there.
So you end up with like this list of symptoms and side effects following medications, which you also then need to factor in as part of that SOAP strategy we were saying about. Factor in what side effects they're starting to experience, so that when you get on session, you can ask them, like, are you feeling nauseous today? Are you feeling a little bit queasy? Are you
feeling dizzy? There might be certain times a day that are better than other times a day, or certain times of a week that are better than other times. It might be based on when they've eaten around their medication or had fluid around their medication. There's all these variables that come in that go, actually, this is the best time to train. And I know you're going to be that's going to be like a late lunch break almost, but is that possible? And you're going to really challenge the client to get the most out of their their world, I suppose, out of their session and out of them moving forwards towards their goal.
Yeah, exactly. And then within that, I would always ask at the beginning of every session when working with the client,
has anything else changed since we last saw you? Which, I'm going to be honest, should be standard practice for anybody.
Everybody.
Pilates, yoga, boot camp, HIIT, spin, aqua, PT, one-to-one, semi-private. It don't matter where you are in it as a fit pro. Has anything else changed since the last time I saw you?
and also ask, have you had your medication today as
Yes.
planned? And do you have like any immediate stuff with you, like an asthma pump, for example?
Completely, because if they've got asthma and they don't have an asthma pump, it's a no-go. It's now unsafe, because what if something happens? And there'll always be the person of like, well, I haven't had one for weeks or months, and it won't happen today. What if? But you don't want to put your
Not a risk to go for.
It's not a risk to go for.
Not when it only takes just having a pump next to them.
No, completely.
And then the other part of that, in terms of medications, I had several people before that I worked with that I'd be like, have you taken your medication? They go, oh no, I'm not taking it today because that makes me go for a wee. I'm like, no.
That's not how it works.
I need you to take it. Your blood pressure's through the roof. But they don't really necessarily think about it like that because they don't see the immediate effect of taking the medication. But the risk increases massively if they're not taking
because we've
it.
got to remember that training is a stressor, and effectively what we're saying is someone has been given a stressor for a period of time that has helped bring about a common clinical condition. Okay, so for example, I might sit awkwardly at the desk, okay, for 8 hours today, and that has been a stressor on my posture, and then I might get up and go, oh, I can really feel my back. And then I might lay awkwardly and avoid that overnight. I might wake up and go, oh, I can really feel my back. And that is a stressor on my body. Okay, so what we're saying is everything we do day in, day out, how we move, how we eat, what we eat, when we eat, the training, what we're exposed to in terms of stress, light, sound, noise, sleep, they're all stressors. They're all sending our sympathetic nervous system into a state of...
Fight or flight.
Yeah, say that again.
Sympathetic.
Yeah,
Fight
sympathetic.
or flight.
And we're responding and reacting to that all the time. And so we've really got to consider that training is an incredible stressor on the body. Okay, which is, I suppose, is probably why walking is by far the most prescribed form of exercise for so many people, because although it is a stressor, it's the lightest, non-impactive, with the greatest benefit.
And the thing that
from
so
a cardio,
that people can fit into their world so much easier without other problems.
And
like
it's achievable, it's realistic. The human body is designed to have forward locomotion. It's innate to us. You don't have to think about it. It's something that's ingrained into us. And I think, the moment we consider that any planned session, so exercise, activity, thermogenesis, is a new stressor on the body, that directly impacts the common clinical condition they have. That the moment we start planned exercise and we start moving, the muscles start contracting and relaxing. Now that pulls on across the joint, that makes the joint now acts in a certain way, which can really kind of aggravate any of the musculoskeletal conditions.
Yeah.
So we really need to consider how much of an impact our stressor added to their world is having and is not detracting from their result.
Oh, I like that. That's very smart.
Because it could be that actually by training, we're actually doing more harm than good. So we really need to sit back and go, okay, so there's my soap, there's my, I don't mean as in like washing, okay, but there's my subjective. I know as much as I possibly can tease out my clients. I've gone 3 to 5 questions deep. I've really uncovered, gone under the carpet and found out of their, what's really going on, what they think, what they feel, their emotions around it. And then I've gone on to the objective. Now the assessment is here and I'm going, okay, if I plan this, if I go on to plan that, am I making a step forwards and not a step back at the same time?
I think the biggest description of that, like where you can really see it as an example, is if you've got somebody that has obesity and let's say they've got a couple of other comorbidities, let's throw diabetes in there as well. Type 2. And then they also have depression and stress. So the mental health side that they've talked to you about but maybe not considered. And you get into the gym with them and you find out they feel really conscious inside the gym, they feel very conscious about what they're wearing, they're unsure about stuff. The exercise you now do with them could put their, although it might be creating a nice calorie deficit for them and moving them towards the achievement of their obesity goal,
yeah.
it could be taking the back step on
And so
the mental
we
health
need to
stuff.
be, I like to figure this out. I like, you know, when I'm in a classroom, I'm on a one-to-one or teaching this, I like to consider it like a bit like a Sudoku puzzle, okay? But the end goal is to obviously get all of the whites on one side, the yellows on the other. But along the way, there's
That's not Sudoku.
Not Sudoku, Rubik's Cube.
I was like,
I meant a Rubik's
how are you
Cube.
going to do this?
Yeah,
Rubik's Cube.
meant a Rubik's
Okay,
Cube.
there
I got
you
that.
go.
In my head, I knew the picture, but I said the wrong thing, so apologies. But you get my point. So on the one side, all the blues, on the other side, all the reds. But there's a few different ways of getting there and unpiecing that puzzle. And I've got to think of all of the possible combinations in order to make that happen.
Yes.
Like you just said, you know, yeah, they might need to sit in a calorie deficit, and then we go into a gym, we do an exercise, but how does that impact on the mental health side of this game, which is the yellow side of a puzzle? Okay, now I need to unpick
And does it
that,
make their knees worse if I do this particular exercise?
which is the blue side of a puzzle. Yeah, completely. And so then, you know, the other side to that is, let's go down, they're overweight, obese, BMI 35. They got type 2 diabetes. We create a calorie deficit, okay? And they have let's say they've expended 500 calories. And they said, yep, I've had lots to eat today, I'm perfectly fine. But actually, they've still sat in a bit of a food deficit as well. Now they go home from that and, I don't know, something stressful comes in, or around their depression or anxiety, whatever it might be, something happens in their world, in that situation. And now they go, I'm going to go and, based on my thoughts, feelings and emotions, I'm now going to eat this. Okay, and because they're in a calorie deficit, they might be in that kind of, I'm going to call it hangry state, where they just go, I just want to eat something quick. I don't want to bother about food prep or whatnot.
So a quick grab or something.
A quick grab, okay, and now they've ended up consuming something that doesn't benefit them from a diabetes perspective. Okay.
I'm going to grab a bowl of Frosties.
Whatever. No, let's not demonize any food. I don't want to do that. But
you mean something that's got a high sugar?
Yeah, completely energy dense. And now, based on how they feel, based on the reaction or response of what they've eaten and their insulin levels, now there's an impact on their condition.
Yeah.
And then we all know that the kind of a correlation between what I think and what I feel goes around to our behavior, which is our Mercedes model, which we've talked about in previous episodes. And then if I've eaten something, I then might have kind of this cascade effect of maybe guilt, shame, or blame. And then that leads to another karmic loop of this Mercedes model.
Yes.
And then we kind of almost can stay stuck within this world of not making progress forwards, all because I was too much or too far into a calorie deficit on one particular day.
Wow. That's
I think
quite
I got.
cascade.
Do you see? I know I've painted.
I see what you mean though, because you're basically saying that one thing can sound like the best
Best thing.
action,
And
but when
actually-
you go down the line, you might find that's the one thing that makes something else worse.
So you know, you see it so much on social media. Calorie deficit, and yes, you've got to be in a calorie deficit. I get that, but you know, taking a much more conservative route and being the tortoise and not the hare on this occasion would be
not having a
lead.
massive deficit,
Yeah.
so that they actually feel that it's sustainable over a longer period of time.
But also in the micro, right, like in the day, like right now, because the client could force, say, a 500 calorie deficit from exercise and a 300 or 400 calorie deficit from food on that particular day. Now they're like 800 to 1,000 calories down on their day. Like if I asked anybody listening to this that I'm going to take away 1,000 calories from you today, okay, you're going to be hungry to a degree. And if you've also got diabetes and your ability to manage your insulin and blood glucose levels is already a little bit out of whack, okay, and then on top of that, you've also got a mental health condition, of regardless which one it is, you're now in this kind of cluster storm of thoughts, feelings, and emotions that don't necessarily set you up for success. It would be, I'm going to say, easy for a client in this situation to find a reason to fall off the wagon. And so it's my job, your job as a coach, to truly see life through their eyes and go, how do I get you from point A to point B, across this chasm, across this rickety rope bridge that has plenty of opportunities, by the way, for you and I to mess up and for you to fall off this wagon, fall off this rope bridge. But how do I put the guy ropes on this bridge? How do I lay down more solid planks for you? How do I place more planks, more smaller steps for you to get to your goal, as opposed to you having to kind of like wobble across this rickety old bridge? How do I put
great.
a suspension bridge in here for you? How do I make this like guaranteed that you get to the end
And it's
result?
also it means that less is sometimes more.
All the
so
time.
it can be
Yeah.
it can be so overwhelming when you're stacking up all the things you want them to do, and you're talking about like reinforcing this bridge, turning it into a suspension bridge.
Yeah.
The temptation is, okay, cool, they now need a calorie deficit, I'm going to give them
need to
this
do
recipe
this,
book,
this.
I'm going to give them this food diary to do. You give them all this different stuff that they need to do, that actually sometimes too much too soon
Well,
is
I'm
actually
gonna
the
say
reason why they're
all
going
the
to
time,
fall
I'm
off.
going to say like the people
So overwhelming.
if I look up to the number of people I look up to in the fitness industry, and I look at how they work with clients, and then I look at say how you've worked with clients, it's not necessarily been like the less is more. You've worked with the elephant in the room, and you've gone right for the
one
next
thing.
we're going to knock over this one domino, and we're going to spend this domino is going to be a 1 week or a 2 week or a 4 week domino to push over. Let's go and push this one domino over. Let's go and like get this one thing sorted, and then we can move on to the next
one
big
thing well.
one thing.
Yeah, exactly.
Yeah.
One thing, one aim, one goal,
So out
one
of all
thing.
of the conditions, okay, if there's one domino you've enjoyed helping the client push over, or one domino that you've seen have a big impact on someone's world, what's it been?
Whoa. Put me on the spot a bit.
Do you want me to go first?
Yeah, you go first.
So mine would be early on in someone's program. It's such I take it for granted, but having a very consistent shopping day, whether that be in person in Sainsbury's or Tesco or wherever you want to shop, or delivered online. Okay, so it's deliberately delivered on a very particular day with a clear set of meals that goes past the next week's
Oh, so you don't
shopping.
get to the run out, I need
So
a
there's
takeaway.
no run out opportunities, okay? And then figuring out what goes on that shopping list and making that happen.
Yeah.
And I found that, for a majority of clients I've worked with have been overweight, obese. That's what I've loved working with clients on that. And then if I've nailed that and helped the client push that over in the first, I'm going to say 3 to 6 weeks.
Yeah.
And they go, actually, this is quite straightforward now. And I'd wait for that kind of conversational language that reinforces that they can do this domino on their own. I'm like, cool, win, let's go, next domino.
Yes,
And I
that's
found
good.
that
So
to be
yours is food.
incredibly powerful, because that, for me, that domino represents not just them getting a result, but the household getting a result. So that could be their husband, their wife, their kids as well included, or their flatmates. And go from there.
So mine
Go for it.
is about having a challenge or a set goal that is in the short term.
Perfect.
So with health related, it's talking so long term that it can
The
be
delayed gratifications.
Do you know what I mean? You want something
Yeah,
a little bit
yeah.
sooner.
I
So
like that.
could be just noticing
Perfect.
some of the changes from your objective, where you've done some of your testing, or from your subjective even. It could just be a little challenge. Like I remember one guy came to me, and he's post-stroke, so he only has control over his right side, and he walked with a stick. His overall goal, I love this goal, was that he wanted to be able to take a cup of tea up to his wife in bed.
Do you know what? Like, phenomenal.
Love it. Love that goal so much. So when we were working through all these different things, we're like, well, what does he need to be able to do in order to get a cup of tea up the stairs when he can only have one hand that can hold the tea, and
Slow progress, right?
and he can only and he wants to hold on to the
Banister. Yeah,
that's
handrail.
it, banister as well. So he's got to hold on to that as well. So how do we do it? So we had to chunk it down into these little mini kind of goals that we kind of just made up ourselves, which is
Perfect.
fine, because he had this like, I'm going to get to the third step, or first of all I've got to like make the tea and walk it from the
And that's
kitchen
what-
to the stairs without dropping it.
I think, more so say at level 3 PT, we do a fitness testing day, and you're actually assessed on that to some degree as well. And inside that, there's always normative tests, like the Chester step test, the Rockport walk, the Astran cycle, the 10RM test, and all of those. And then you could look at Vartex, so making sure that every test you do is valid, accurate, reliable, time-bound, enjoyable, and costly. Okay, which we teach in FitPro 31 as well. And what I love about that is you could take that Vartec or that principle or a protocol of how do I reproduce this? How do I make sure this is accurate, reliable? How do I make sure if I did it now and I did it in 4 weeks' time, it's under the same conditions and I would get an accurate result to make comparisons to,
Yeah.
to say there was a significant or no significant difference. So for example, your goal was, well, how far can you get through making a cup of tea? So what can I control inside those variables to measure that right now? What's the current status? And then in 4 weeks' time, what's the current status? And did we improve?
Exactly. The problem we had at the beginning in this situation was that he couldn't walk without his stick, which meant he couldn't then hold anything.
Hold it, yeah.
So he had to first get to the point he could walk without the stick without too much movement.
Did he get his goal?
He did.
There we go. How long did it take?
It took about 3 months, and he
Well,
got
that's pretty good
It's pretty
effort,
good,
right?
but he literally had to then put the cup of tea on the step, then pull himself up, put the cup of tea on the next
But the
couple of
beauty
steps
of that
up,
is
pull up.
the beauty of that is the first goal of
And
making.
it was a commuter mug with a lid on.
Amazing. But the first goal could have been achieved inside the first week. And what I love about those challenges is it keeps the client kind of almost like a carrot at the end of a bit of string right in front of your nose. You can see it, you can almost touch it, but you can't grab it easily. You've got to really work for it.
Yeah.
But it's not too far ahead of you that you can't see it or smell it or touch it or taste it.
Yeah.
So having that challenge or short-term performance-related goal is absolutely key for any client, regardless.
Keeps you excited, right?
Yeah, completely.
Yeah.
So in my world of running would be like, so the end goal is an ultra marathon. How do I perform 100 kilometers? But I'm not going to go out and do that today. And it's so far away. I don't really get any gratification from that. And although it's exciting, it's still maybe 6 months away. What am I going to do by the end of a week? Well, I'm going to do my first 10K. And so I go, well, that's my first performance related goal. And I keep building this bridge across that chasm until I get there.
And if somebody's goal is as long term as I want to come off some medications, then we're definitely going to need a good amount of time. So you're going to need something else.
Completely.
I did want to talk about some medications.
Go for it.
Should we talk about some medications?
There's hundreds of medications, and you can get a book with all of the medications in. And what I like about this, it talks about what the medication does, why it does it, the anatomical, physiological effect on the body, so its functionality, the side effects. What if you're, say, pregnant? What if you've got another condition? What if you've got another medication? What are you likely to see in terms of symptoms in this? And
exercise considerations,
yeah, it's
all
wicked.
sorts of different things. And I just
so
thought
the link will be below for that as well.
Yeah, there's loads of different ones of these, but essentially it's a medications dictionary.
Cool, I like that.
Medications dictionary. But there's a couple of medications in particular that I think, for me, are the ones that when I hear about them, I always think, oh, I've got to be mindful of those side effects. Oh, I've got to be considerate about those from a FitPro point of view.
Yeah.
Especially, obviously, with every medication, there's stuff going on.
What I like about, well, I know a few you're going to mention, but inside the referral course and the new supporting clients with clinical conditions course that starts next year, there's a table that you do in there, which is, I suppose, it's a worksheet at the end of the day, but it has all of the clinical conditions, so all 14 of them, and then you write down all of the medication side effects, and basically you create your own, I'm going to say, dictionary of 14 conditions. But what I love about that as a task in particular is it gives you the inquiry and questioning skills, so that when a GP or a client comes to you self-referred and fails a PAR-Q and they go, I've got fibromyalgia, that's not one of the conditions in the current exercise referral course, but it will be in the new one. You have the question and inquiry skills to go and look up all of the information about fibromyalgia, and you're still the best person to work with them.
Yeah,
So
the inquiry research.
That's what you get from those. So you don't necessarily need to remember it all.
Oh, no.
But you do need to be able to. That's what I love about the level, any course really in learning, is what you're being tested on, I suppose, is your ability to find information,
to go and get it,
and hunt the right information. Like, the world doesn't need any more information. It's already out in this big wide world. No one can say it in with any more clarity. They're just going to say it in a way that you understand.
Yeah.
And so what we need to do is to go and find reputable, valid sources of information that says, that's what that medication means, and that's what I can and can't do, and they've said it in a way that I understand, and I found it. And that's what I suppose the exercise referral course does. It gives you that questioning skills to go and pluck the information from this big wide world and go, that's what the facts are.
And then you can bring that into
and
your
you can
soap.
bring that into your soap completely.
Yes.
Okay, so I think that's the hidden benefit, which I think a lot of learners don't get from level 2 or level 3. It's like, why am I doing this worksheet? Well, the worksheet is teaching you how to find and source information.
Yes.
It's to pick out key buzzwords. it's allowing you to recognize the structure of how to communicate.
The main, like you said, the ATSM guidelines for the fit
Yes.
principles of exercise. What should they and shouldn't they be doing?
Exactly.
How much is
Yeah.
recommended? The medications
Precisely.
that they might have. What possible side effects they'll have.
And,
different considerations.
you know, we have to kind of almost recognize that maybe 70%, maybe more, of what we read or what we're exposed to isn't actually useful or relevant or fact. And it's the inquiry skills to go and pick out what I need inside my individual client and say, right, that's in my SOAP, that's in my subjective objective assessment, and that's why I'm planning it this way. Cool. So conditions, medications. What ones we're going to
Medications.
talk about?
I'm gonna zoom through a couple. So
Okay.
first of all, corticosteroids. So steroid use in particular. So steroid use for, and I don't necessarily.
We're not
mean for-
talking about big muscles here.
The same effect.
It's same,
because
yes.
It stimulates growth.
Yeah.
Which is what it's for. So you get corticosteroids are used for asthmas as part of their inhaler,
Yep.
and they're also used for injections into joints to help lubricate around the joints
So
and help
reducing inflammation.
Yeah, exactly. So the problem with corticosteroids, and any steroid in particular, is it changes how we use calcium in our body and vitamin D in our body, which therefore in turn can relate to the worsening of bone mass density. So the reduction of bone mass density, which, just like our last podcast episode,
So
falls
somebody,
into
so
osteoporosis.
for example, somebody might have osteoarthritis, which would be in their fingers, for example, or one of the sites, so inflammation around the fingers, which is incredibly painful. It swells up, it's inflamed, and then they have what was the steroid called?
corticosteroid.
Corticosteroid to alleviate that. Now they've alleviated that discomfort and swelling. They've got more, I suppose, acute range of movement back because of this external stimulus.
Yeah.
However, we've now, for a better word, upset a calcium and magnesium level in the body, and
vitamin
chromium,
D.
vitamin D, and now we're leaching calcium from the bones, which in turn causes osteoporosis and osteoarthritis, which we're now back to square one. So it's
Yeah.
kind of like,
Osteoporosis, yeah, exactly. And also, if you think about somebody,
you're damned if you do and you're damned if you don't.
yeah, if you know anybody with asthma and that's always like puffing on it more than they probably need to, then it's knowing that there's that sweet spot between where you need the amount you need to control the condition you have, but also not too much so you don't go on and cause more problems.
Well, I had a client 2014, 2015 that fell over, broke their wrist from where they fell over. Okay,
downstairs, yeah.
down the stairs or up the stairs, and because of that, that was from osteoporosis as well. Okay, and overweight and obese with asthma, and we challenged that through walking predominantly and upping NEAT, and also through nutrition and mindset. And weight did, I'm going to say, radically drop off the client, and we had an incredible transformation inside an 8 to 10 week period. Actually, when they went back to the GP, the asthma pump was declined for repeat prescription because actually her asthma improved.
Oh, nice.
And when we deep dive into that and you think about the side effect of excess pump use over the years is actually causing weight gain, you kind of like, how much of a consideration was that? Because as we went through I'm going to say it was an 8 to 9, maybe 10 month time frame all told to this point, the use of the asthma pump radically declined to the point
As she got fitter.
As she got fitter, but as weight dropped as well, and confidence, and just that recognition that somebody else had her back at this point. She didn't rely on the asthma pump. So why was the asthma pump being used? Was it being used because, there's a whole host of reasons why it was being used, but was it because she was short of breath and needed to use it? I'm going to question no at the time. And the client will turn around and go, well, actually, I don't know. I didn't even realise I was puffing on it. Okay, so as a reduction of this came down, how much of an impact did that have on her weight as well?
And how much did it impact on the fact that she broke her wrist?
Yeah, completely. There we go, in the first place.
Someone else could have fallen over and just got back up.
Well, you see it all the
With a little
time, don't
bruise.
you? You know, I
always
saw
falling over.
I saw you fall over the other day, but you didn't actually fall over. You didn't actually put your hands down. But for some people, that could have been a broken hip or a broken wrist.
Yeah.
You were very elegant as you danced your way out of it. But do you see what I mean with that? Cool.
Yeah, exactly.
Like it.
I want to segue into
Yeah, today.
statins.
Cool.
So statins for cholesterol. So things like simvastatin would be quite a classic one. Now the classic,
No, I was like classic. I was thinking like as in like
Beethoven.
you know, like everybody wants to be on this.
Oh, it's classic.
Yeah, it's classic. It's like
classic.
you don't want this.
Most
Most common. I think that's probably a better
And it
word.
reduces the job of it is to reduce LDLs.
Cool.
So, it
low density
reduces low
lipoprotein.
density lipoproteins.
Cool. And we talked about that, and we kind of put a couple of myths to bed in that episode, which was episode 3.
I think it's one of the first ones, wasn't it?
Yeah, maybe all around hypertension and hypercholesterolemia and all that types of thing, around why we've got LDLs and HDLs in our body and understanding some of the myths around those. So go back and have a listen to that one again.
Yeah, but the thing I find really interesting, I always have about this particular medication, is that the most common of the side effects, and there's quite a few that aren't very nice, is muscle pain. So if you've got somebody that's got severe muscle pain from the tablet that they're taking in terms of their statin, and then you come to them, you bring them into exercise
And give them muscle soreness and DOMS.
Then you don't know what is DOMS and you don't know what is the pain that they're experiencing.
Yep.
It makes it really hard to monitor intensity and look at overload with that
Yep.
muscle anyway.
Because it's already in a point of not necessarily overload, but a point of discomfort.
And they might not even want to exercise because they have pain.
Yeah,
If you
great
think
point.
on a day when you have really bad DOMS and you don't even want to walk up the stairs, you're not going to even want to go to the gym.
It doesn't say, it's not inviting, is it?
No, it doesn't
No.
make you feel great.
And if you're nodding your head going, yes, it does, Neil and Hayley, you're crazy. I want to let you know, I want you to consider that you might have a sadistic streak as a fit pro.
So if they're already feeling this...
In fact, if you are listening and you think you have a sadistic streak, then inside the inner circle, I want you to hashtag I am a sadistic fit pro.
Nice. See if there's any of those.
See how many people come out of
I
that
think
one.
we might have a couple.
Yeah. There we
I have
go.
no idea what I was talking about.
Around muscle soreness and
Like DOMS and muscle
simvastatins
pain.
and muscle cramps, yeah.
Yeah, okay. So therefore the best type of exercise might not be to go and create a very sharp increase in muscle adaptation like we would probably do with strong resistance training to overload. Instead, it might be to include things like flexibility, a decent warm-up, neat, walking,
Well, you got to think about
and gradually progress.
Rome wasn't built in a day. Yeah, gradually progress. You might go, you know what, I really do need for clients to reach some form of overload, but it doesn't necessarily have to be in week 1, week 2, week 3, week 4. Think about this bridge across this chasm from point A to point B. It might be that overload doesn't appear until mesocycle or training cycle 3.
Yeah.
But there's some preparatory dominoes or elephants to push over before you get to the point of that's what muscle soreness feels like. And my client's educated enough to go, the difference between muscle soreness and my side effects of my medications are X.
Yeah.
I get that. It makes sense to me now as the client. And then you can push forwards.
As you build up their lifestyle changes, you're also then getting them to the point where hopefully they won't need the simvastatin anymore because their cholesterol is at a better level based on what they're eating, what they're moving, etc.
One thing I've enjoyed doing with clients has been educating them on the comorbidities of their condition and the medications, because from my experience, and this isn't meant to be it's not meant to be a derogatory comment to the medical world, because I've absolutely loved working and training alongside them. However, 9 times out of 10 I've been the first person to sit down with the client and talk to them.
Probably.
I think it's a time frame thing, to be honest, and truly give them the time and empathy around their condition to get the medications book out of their box of medication and the leaflet that comes with it, and talk to them about it. Because let's take it, I'm going to say 99% of medications say avoid alcohol, okay? Let's be honest, 99% of clients aren't going to avoid alcohol, okay? There's going to be a point in their day or their week where they go, just having a glass of wine, it don't make any difference. Yet consider that it does make a difference. So
And sorry, quick story. And it was this guy called Pete, and he basically was adamant that it was okay to drink alcohol with it. What it meant was you can't have it with it. So in the same gulp.
Oh, amazing! So don't swig it down with a bottle of Jack Daniels.
But it's okay. So he would literally have it with water
And
while standing at the bar, whilst ordering his pint.
Oh, amazing! Super.
But it's okay because he didn't have it with it.
But what I love about that as a part of a consultation, not necessarily in consultation 1 or 2 or that double consultation, but early in the program, remember Rome wasn't built in a day, and I want to build up a relationship, a rapport, and actually some conversations can be parked, in my opinion, quite early. I know I need to deal with that, but it's not the elephant in the room just yet. That elephant comes in a couple of weeks' time. But then having that, real raw and relevant conversation around their medication, around their alcohol intake, or educating them on, when to take their medication, educating them on the side effects of what to look out for. From my experience, clients have gone, I wish I'd have known that almost sooner. Thank you. Like, I can't thank you enough. That makes perfect sense. That makes sense why I don't sleep like that well at that time of night. That's why it makes sense why I wake up a little bit early. That's why I wake up 3 or 4 times a night for a pee. That's why
these symptoms are worse.
I feel a little bit grouchy. That's why
maybe some of the side effects from the medications become worse when combined.
Yeah, completely. And you're like, actually, you've really just shined a light on it. And then they go, actually, because of that, and you can now start to make what I call modifiable changes. And that's when the client, I think that's because I've left it further down the line to deal with this elephant. Okay. The client turns around and says, would it help if I reduce my alcohol? I'm like, yes, it would. And now the client is becoming more suggestive on their actions they're going to take.
Yes.
And that comes down to having a good SOAP, subjective, objective, and a clear assessment and saying, I'm not going to deal with that elephant just yet. That's going to be logically periodized and progressed in, and that's going to become the big strut of my next part of my bridge to get across this chasm.
Oh, I like it.
Nice big metaphor today, isn't
it?
Yeah, but that's been key. Rather than me, for a better word, putting words in their mouth and coaching out of them, I like to see a coach as a lighthouse where you're literally going to ask a question at a very particular time and shine a light on an inquiry area, and they give you the answer, and it's their answer that makes them move forwards.
Yes.
Rather than me being the tugboat,
dragging them,
going, just don't drink alcohol, it's bad for you, don't drink alcohol, you can't do this, X, Y, and Z. Because the moment the tugboat lets go, the tide will take them back to where they started from.
Behaviour change is a massive part of anything health related, and understanding that. In fact, it's something I really like about the new qualification version that's coming out, is that they've put a whole section of motivational interviewing and much more on behaviour change to reflect the need for it. Because we always put it in our exercise referral quite heavily in terms of coaching our clients, but I think now it's really combined.
But I think also like it's discussed, like we're talking on here. At the end of the day, this is a free podcast for anybody to use. Now, we talk about motivational interviewing, but it doesn't necessarily tell you the tools to actually go and deploy. Like, what is decisional balancing? What questions do I ask to take somebody from A to B through that decision-making process to move forwards, and for you to be the lighthouse, to ask for world-class questions? What are those questions? Why are they worded in that way? Why are they timed in that way? Why are they that particular length? Why do they have those verbs and those nouns in? Do you see what I mean? You're really looking at the language used to draw the client in and go, there's my answer, bam, I'm moving forwards. And that's what I think I'm really excited for when we develop the new syllabus.
Yes.
To place even more of those tools in.
Yeah, like real usable tools.
Because you come into, say, exercise referral with a set of level 2 tools or a level 3 PT tools or Pilates or yoga, and the tools are very refined and biased, I'm going to say, towards not just planning, but more so exercise prescription and exercise doing, exercise action.
Yeah.
Whereas now the tools become sharpened, but also we place new tools into the toolbox to go, that wasn't the only route to get the goal.
It's about lifestyle. It's about all of this.
Yeah. I can build this bridge across this chasm and be the lighthouse. That's how I do it. Perfect.
The bridge across the chasm, I think, is the metaphor of
completely. Today. What's really good, actually, was the title of one of the podcasts with Dr. Rory McGill, who is a GP referred.
That was in season 1.
Season 1. So it's we'll put the links below on that one. It's called, I think it's called A Bridge Across the Chasm, or A Rope Across the Chasm. Yeah. And it's an incredible, I think it's probably about an hour and a half with me and Dr. Rory McGill talking. It's really, really good. And he talks a lot about behaviour change. So as a bit of a kind of to tee this up, Rory was a GP in the NHS for, I believe, about 30 odd years. And he went on a course around, I think, like motivational interviewing. And it was that first point where he kind of questioned medications. And it was from there on in, he went on his own journey to a point he, I suppose, fell out of love of giving medications in the GP world.
Yeah.
Okay. And then he went on to become a holistic doctor, kept his medical license, but to this day vows never to give a medication again and looks at holistic therapies. It's phenomenal.
Fantastic.
And I've loved working with him.
Yeah, really aligned.
Credit.
Exactly.
Where credit's due, because it's just been phenomenal.
Isn't it just? Cool. Absolutely.
So next step.
Yeah.
Are we done?
We're basically at the end of today.
I'm really sad. We can't leave it now. What else can we talk about?
We were talking about what we love most about the exercise referral course, but I know that you kind of went there already.
Yeah. Okay.
So for
I'll
me-
ask you. I think I've got one more thing I wanted to say, but I'll let you go first.
So for me, the thing I love most about the exercise referral course is the transformation of each Fit Pro to kind of go from where they start off. And I said this at the very beginning of today's episode, but that starting off knowing you want to go and help a client, but then realising you probably don't really have the tools to be able to do it. And then through exercise referral, as they're learning about the lifestyle, they're learning about behaviour change, learning about how to layer on the nutrition and the activity, they then go, that's how I help this person.
And at the beginning, there's a level of, I'm going to say, naivety. And I've been there, I get it, because I'm doing a course and I felt this recently. A bit of naivety, a little bit of ignorance, a little bit of arrogance early on of like, it doesn't matter if a client's just a little bit overweight. Like, does it matter if they refer a park you at BMI 32?
There can't be much more complexity to it.
Can't be much more complexity to it. And then as they get through the course, you're quite right. It's like, like the rabbit in the headlights goes, oh my God, like there's so much more to it. And actually this is really interesting, but it's not actually that complicated, if that makes sense.
But also their transformation is massive because they start valuing the knowledge they've learned.
Yes.
So with every Fit Pro that goes through, they value the knowledge, which means they now value the service they offer their client at a much higher rate.
Oh, great
and
point.
Therefore self-confidence goes up, your ability to charge for what you are worth
goes up. And you get a result.
Yes.
And the clients are happy, you retain more clients. It's wicked. I like that. Cool.
What was your big takeaway?
I suppose I got
Or
two
big thing that you liked
big
about it?
takeaways. I think one of the things I love about the course is the conditions table, which I believe is going forwards into the new course
in its own way.
But it's ultimately where you create your own, I've mentioned it already today, is that dictionary of what's going on in each condition and understanding the kind of the 3 to 5 key points of like, what's the pathology, where did it come from, how does it get worse? What would I do from a nutritional standpoint, an exercise standpoint? What's the FIT principle? What are these side effects for medications? And I love that because it's just this tool in the toolbox that it's like adding a superset or a giant set of like, that's what I can do, or that's what that makes the difference of, or that's the physiological effect. And that worksheet for me, although is quite
really organised
in
notes,
depth,
isn't it?
it's just really organised notes and it takes it forwards. But with that comes knowledge, and with that comes confidence. And what wraps that up, just like in all of our courses, we talk about behaviour change. And I think that's my biggest takeaway, is the ability to take somebody from A to B, to educate them in a way with very clear communication, in a way that empathizes with the client, sympathizes with the client, in a way that challenges the client's view, converts their mindset from A to B, and takes them across this chasm.
And that's one of the things I'm really excited about for the new version of the course that comes out. So you've got more of the behaviour change, more of the mindset side, more of the motivational interviewing and practical tools you can use, but also the new conditions that are going to be added.
Well, they're not new conditions. They've always been around for many decades.
Yes.
But we're talking about conditions that actually go back maybe 6 to 8 years, were actually in exercise referral. Now when they went out,
then
now
they went out of scope of practice.
And now they're coming back in because they're seen as more common clinical conditions.
And they include hyperthyroidism, hypothyroidism, cancers, fibromyalgia, and the neurological conditions as well.
So inside neurological, we're talking things like stroke, that type of thing.
Stroke, Parkinson's,
Perfect,
MS.
wicked.
And there's also about ME and sort of connective tissue issues as well.
Wicked. So I think although there's some new additions coming, if you already got our course for exercise referral, you automatically get all of the updates as well, which is really exciting.
cool.
And you can still go ahead and work with those people as well.
As you're learning.
You're learning. So I think ultimately it's a name change, because what we're really looking at is exercise referral is working within exercise referral schemes, and those kind of exercise referral pathways or schemes and clinical conditioning groups. They're not really there as such anymore. And I think even more so in time, a coronavirus world where the focus is so far into kind of where COVID...
Well, healthcare has changed so much in the last decade at least. And if you think the last exercise referral was created about 15 years ago.
No, 2008 was the last shift.
2008?
Yes, 2008.
Still quite a way ago, isn't it?
Yeah, 12 years ago.
12 years ago. So there's been a lot of changes in just how the healthcare system works.
Completely.
And where funding comes from in 12 years. It's quite a lot.
If you think about like right now in this last 12 months, how funding has been moved and where the kind of the light of health is being directed, if that makes sense. Getting people with common clinical conditions at high risk into an exercise referral pathway, meeting up, social mixing, like I just don't see it being the same structural thing. And that's what I'm really excited about this, from just purely a name change, because it's about supporting clients with long-term clinical conditions.
It doesn't talk about it being a scheme.
And that's exactly really what exercise referral is about. It's about working with people that have referred a PARQ, and how do I get them from A to B across this chasm.
Exactly.
Superb.
Nice, I like it. I've really enjoyed today.
I've enjoyed them all. I'm still sad, but we've got to do one more. And there we go. So if you have enjoyed it, let us know what your biggest takeaway has been. Drop a comment below, whatever social platform you're listening on, in iTunes. Obviously, it's a 5-star review, given.
Yeah.
And if you do have the time, we'd really appreciate it if you tag us in on your stories or inside the Parallel Coaching Inner Circle, and all of those links are below. So anything else we've mentioned today, any links, blogs, podcasts, all of the links are below.
In the show notes.
And we will see you on the final episode of season 4 next week. See you later.
Bye.
Hi, I'm Neil Bergman.
And I'm Hayley Bergman. Over the last 10 years, we've helped thousands of fitness professionals to get qualified, learn with simplicity, and coach clients with confidence.
We're the first to say that learning and being a Fit Pro doesn't have to be hard work, and that with the right structure, support and resources, you can become a confident and knowledgeable fitness professional that is dedicated to more.
So how do you learn, qualify and kickstart as a Fit Pro? This is the Fit Pro Sessions podcast with Parallel Coaching.